I just wanted to talk a bit about the context of pregnancy-associated SCAD and subsequent pregnancy. My colleagues, Dr. Scott, Dr. Kotsko, will speak a bit later on this session about details outlining what we are learning. I have learned so much in caring for all of our patients with coronary dissection and particularly around pregnancy. Key themes, aside from the fact that our moms presenting around pregnancy with SCAD horrify themselves, their families, and their doctors. SCAD is the commonest cause of heart attack around pregnancy. And for reproductive age patients with a history of SCAD, family planning, pregnancy counseling is often needed. And I think we are getting better at individualizing that approach for each of our patients, depending on their needs and their background and wishes. Preconception counseling has evolved also over the past decade with the inception of cardio-obstetric clinics and the multidisciplinary relationship across lots of hospital campuses between maternal fetal medicine and cardiology. What we know and what we need, though, is additional guidance regarding pregnancy management in patients with history of SCAD, and there we're continuing to learn. We often cite this visual from a 2017 publication by our Mayo colleagues that really highlights how pregnancy-related SCAD is different from non-pregnancy-related SCAD. The illustration on the left-hand side really illustrates how SCAD is different and how sometimes there is a tear or a disruption in the arterial wall there on the bottom versus sometimes only the bruise or the hematoma, as we call it, being noted on imaging. We know that pregnancy-associated SCAD more frequently occurs in that first month postpartum, majority within the first week after delivery, and that it is often a P-SCAD or pregnancy SCAD more severe as compared with non-pregnancy SCAD or NP-SCAD, as we'll call it during this talk, in that it more frequently causes our patients to present with a more severe, or what we call ST segment elevation, myocardial infarction or heart attack. It more frequently leaves our patients with reduced left ventricular function, and it more often affects the big arteries, the left main and or several arteries. And in comparison to non-pregnancy SCAD, it is a higher risk presentation and hospital course. Our pregnancy-related patients with SCAD are generally older at the time of their first childbirth and more frequently have had a history of multiple pregnancies, and historically have been described to have fewer extracoronary vascular abnormalities, again in a 2017 publication that really called for additional research around what are the hemodynamic stressors, the hormonal fluctuations, the oxytocin release and its relationship in breastfeeding moms on onset of SCAD, and how does the fact that some moms, when they are older or multiparous, relate to risk of SCAD. Also, what is the relationship between hypertensive disorders of pregnancy, peripartum cardiomyopathy, and as many of our colleagues have mentioned, the extracoronary vascular abnormalities like fibromuscular dysplasia and others. And so subsequently, there was a description. Many of our patients wondered whether the risk of recurrence of coronary dissection was different among those of our patients who experienced coronary dissection around pregnancy versus not. And to orient you, on the y-axis is the follow-up risk of recurrent SCAD in percentage. On the x-axis, years out to 5-year recurrence risk. And statistically, there was not a substantial difference in the risk of recurrence for our patients who experienced SCAD around pregnancy versus not. What are the important considerations around counseling for women who desire pregnancy after spontaneous coronary artery dissection? Again, my colleagues will delve into this in more detail. And so to summarize, of course, some women express a desire for continued childbearing after SCAD, and we always touch on alternative pathways to parenthood, which are favored, things like adoption, surrogacy. But if pregnancy is pursued, we counsel to wait at least a year after SCAD. ideally to recover our left ventricular function. We always refine, we assess the individual risk profile with imaging if that's indicated, review the medications at every juncture to continue, hopefully beta blockers, optimize blood pressure if possible. We talk about topics around assisted reproductive therapy if that's appropriate, and also cardiovascular genetic counseling with a special shout out to our last set of panelists and speakers around the GVAS study. During pregnancy, there is guidance around monitoring, and again, Dr. Scott will touch on this in more detail around what imaging is recommended for mom and for baby, and what delivery plans are discussed, most often favoring a higher level maternity center where there is access to subspecialty care and advanced care in the setting of complications for mom and baby. We call those level 3 or level 4 centers, and a preference to vaginal delivery if possible. Just again, Dr. Scott will touch more on this. This is a brief introduction, but we do have guidance around what supports our preconception counseling for women who desire to carry a pregnancy or to consider alternative pathways to parenthood after experiencing SCAD in the past, whether pregnancy related or non-pregnancy related. And those data really come from a total of 59 women carrying 78 pregnancies. Reassuringly, while there were no deaths in this cohort, the risk of major adverse cardiac events was there, affecting 7 of our 59 women. And there were descriptions of what these women's age was, what their history of pregnancy-related SCAD, what their prevalence of fibromuscular dysplasia was. And so we do have some data to support our guidance, although the data are relatively scant, and we are working to contribute to that. Dr. Kotsko will give you more information on what you all have contributed. From a perspective of what are the times, the presentation, the revascularization patterns of our patients who experience pregnancy SCAD, the top figure there in terms of timing really highlights that, as previously described, and again in this more recent 2022 publication, is that our patients who present with SCAD most generally present in the postpartum period about 1 to 2 months, although the 6 months postpartum remains a higher risk interval, less frequently during pregnancy, although certainly a never event. And then moving on to the bottom panel or figure where the presentation in the cath lab, we look at TIMI flow, the spontaneous coronary artery extent, what the most proximally affected coronary artery and segments are, and how the patients were treated in the cath lab, whether conservatively with PCI or percutaneous coronary intervention, meaning ballooning or stenting, or more rarely, of course, coronary bypass, as Lane described. And there we see that, again, our patients with pregnancy SCAD from a 2022 publication here were more commonly presenting with more severe heart attacks, STEMI, that their SCAD extent was more extensive, that they were, however, treated most often conservatively. What are the lessons we've learned so far in further investigating how pregnancy SCAD is different from non-pregnancy SCAD? We know that predominantly it occurs in those first few months, 6 months postpartum, with few cases occurring during pregnancy. Certainly not a never event, though. And although pregnancy SCAD has a more aggressive phenotype, many women are managed conservatively with favorable outcomes. Most deaths in pregnancy SCAD result from fatal arrhythmias. There's really little apparent opportunity for medical intervention. And pregnancy after SCAD carries a modest recurrence risk. It should be discussed as part of individualized preconception counseling, because we know that when those adverse events occur, they are more serious. This is just a bit of an introduction. Dr. Kotsko will give you more highlight of her work in this American College of Cardiology presentation this spring, and with a concurrent publication as well, highlighting some of the unique features that we are discerning are more frequent to our moms who experience pregnancy SCAD versus our patients in the U.S. population at large, as well as for those of our patients who experience SCAD outside of pregnancy. And Dr. Kotsko will give you more. We're seeing some unique reproductive feature patterns there. Finally, thank you so very much to the entire SCAD network, the amazing platform that the iSCAD and SCAD Alliance steering committees have worked to establish, to the amazing Catherine Leon, to our own Women's Heart Center panel highlighted there in the middle, to Dr. Kotsko, and to the amazing Dr. Kim. Thank you.